Our speaker is Grace Otekat, who's a principal laboratory technologist at the Ugandan Blood Transfusion Service. She will be speaking on blood component preparation.
Good morning, everybody. Our topic this morning is blood component preparation. We shall look at the background. We shall look at the importance of blood component preparation, the basics of blood components, blood component preparation, preservation and storage, and conclusion. As a background, blood components are either prepared from whole blood units or apheresis method, but in sub-Saharan Africa, as you know, we have an economy-restricted country. We mainly prepare our components from whole blood. We are not able to afford the expensive apheresis machine. Our blood components preparation was made possible by the introduction of multiple pack plastic bag in the 1949. Before that, it was not possible to prepare blood components, but as the plastic multiple bag was discovered, it was possible to prepare the blood components. Blood components makes it possible to transfuse only that component of the blood that the recipient needs. You don't want to overload this little child with the whole blood. You want to give that very component that the patient needs. The importance of blood component preparation is the optimum survival for each constituent, like platelets. If you keep it in the fridge, it will not survive. So you need to separate it from the rest of the components so that you can better keep it. You are able to transfuse only specific desired components to the patient. Like in our Cancer Institute, most of the patients only lack the platelets, and you would want to give them only platelets and not the red cell, which they don't need. The use of unnecessary components is avoided. Several patients can be treated with blood from one donor. When we collect this blood in a quadruple bag, you can separate into three packs of red cells and 1 unit of plasma. So 3 children can benefit from this unit, and one other person can benefit from the plasma. So 4 people will benefit from 1 unit of blood. So there is an economy of scale here. So the basics of blood components, again, we have the red cell concentrates. In the developed countries, from our colleagues, they now do the leukoreduce. They take away white cells from their red cells before transfusion, and it's a requirement. It's a policy requirement for them. And still in Uganda, it is very expensive for us to do this. Our quadruple bag in Uganda costs like $6. But if you are buying a blood bag which has a filter to remove the white blood cells, then it will cost you close to $30. That is 5 times the cost of what we are using now, and we are not able to afford that. So in Uganda and in the sub-Saharan Africa, most of us are using red cell concentrate, which are not leukoreduced. There is also platelet concentrate. We don't leukoreduce ours, but in the developed countries, they do leukoreduce their platelet concentrates. Then apheresis platelets I talked about earlier on, we don't prepare it here in Uganda. A few countries in sub-Saharan Africa are doing it, like South Africa, Nigeria, Morocco. They do this, but here in Uganda, we are not doing it. FFP is one of the blood components. Cryoprecipitate is another one. And the white cell concentrate is mainly used for research. If you want to culture your bacteria, then you can prepare the white cell concentrate. I think we did this in Uganda for some research which was taking place in Mulago. So this In our blood, we have plasma, about 50% of the total volume of blood, and it's mostly liquid water, soluble blood proteins, hormones, electrolytes, and nutrients. And then the cellular components are about 45% of the total volume of blood. That is the white blood cells, the platelets, and the red blood cells. These are the components of blood. Blood collection basics. Blood is collected in a primary bag containing anticoagulant, preservative. The bag we are using, we use CPDA. It has both the anticoagulant, it has the preservative to keep this blood alive outside the human body for at least 35 days. And for the quadruple bags, we have satellite bags that are attached depending on the type of components we need. In Uganda, we have agreed to use only the quadruple bags, but we have triple bags available in the market. We have double bags available in the market, where you have one satellite bag attached to the primary bag. The triple bags, you have two satellite bags attached to the primary bag. And for the quadruple bags, which we are using in Uganda, we have 3 satellite bags attached to one primary bag. So the preservation and storage of blood, this started way back in the 1978 when the citrate phosphate dextrose with adenine has been in use, and this blood can be kept for 35 days under cold storage of 1 to 6 degrees. So these are the ingredients of the anticoagulant preservative solution. We have the citrate. It mainly prevents coagulation by silating calcium. We have sodium diphosphate, which prevents fall in pH. You know the pH affects the life of the blood. Dextrose supports the ATP generation by glycolytic pathway, and adenine is a substrate for ATP and increases the level of ATP. It's able to extend the shelf life of red blood cells to 42 days. So you are able to keep this blood longer when your anticoagulant has adenine. Methods of preparation, there are various methods of preparation of blood components. One of them is by gravity. Again, in a restricted economy countries like ours, you can still prepare your blood components like the red cells using gravity. Like in Uganda, when you visit us on Friday, we shall demonstrate to you how we collect this blood, keep it in the fridge overnight, and the cells are able to settle down by gravity, and we're able to prepare the red cell concentrates just by gravity. It's a crude way of blood component preparation, but if you don't have the money to buy the expensive preparative centrifuges, you can still use this and be able to provide the red cell concentrate, which our children who are anemic badly need. We are able to remove the excess plasma and leave mostly the red cells. We also have the low and high speed refrigerated centrifugations. These ones are very expensive. We have a few in the country which we reserve for the preparation of platelets and FFPs and cryoprecipitates, but we don't have enough to prepare all the components like red cell concentrate. And then there is also apheresis. Apheresis, we don't have it here, but in the developed countries, if you want, for example, platelet concentrate, you sit there and the machine is able to remove the platelets and take back the red cells to the donor. It's a lengthy procedure. It takes about 3 hours of you sitting there while the process is going on. We don't have this here, but it is available in the market, and we are hopeful that with time we shall get there. So these are the equipments you'll need if you want to prepare blood components. You'll need the collection bags, as I told you earlier on, They are available in the market, the double bags, the triple bags, the quadruple bags. You also need a refrigerated centrifuge. This one will be very important if you need to prepare a cryoprecipitate, FFP, and platelets. You'll definitely need a centrifuge. You need a plasma extractor. This one is a simple machine. You need a cooling water bath. You need a freezer if you have to prepare FFP and cryoprecipitate. You need a blood refrigerator if you have to keep your red cells viable. You need a platelet incubator and agitator. Platelets are quite sensitive. They have to be kept within between 20 to 24 degrees Celsius. So you need to keep the temperature, otherwise it will affect the function of the platelets. Insulated containers for blood transportation. Blood is very sensitive. If you don't keep it within the acceptable temperature range, they will lose their function. Precautions observed in preparing blood components. It starts right at the time of collecting blood. Proper selection of donors. In the previous speaker talked about this. We need this selection to be done properly so that the blood can be useful to the recipient. Because blood can save a life, but blood can also kill if you don't select it properly. We need clean and aseptic venipuncture sites. On our skin, there are skin flora, there are bacteria, and we need to clean the site properly so that as we remove blood from the donor, we don't contaminate the blood with bacteria. Blood, as you all know, is a very good media for bacterial growth. So if there is only one bacteria remaining on the skin of the donor and it enters into the blood, you are going to end up with millions of bacteria in that blood. That blood, when transfused, you'll end up with sepsis, which may kill that patient within hours. So we need a clean and single venipuncture. You need a rapid and continuous flow of blood donation in less than 8 to 10 minutes, depending on the component you want to prepare. For example, platelets, you need to collect this blood rapidly and continuously, because if you don't do that, you're going to end up with clots. So the process of clotting removes platelets from your blood. So if your collection is not proper, you are going to end up with that blood where platelets is already used up in the process of clotting. You also need the correct amount of blood proportionate to anticoagulant. The ratio is very critical. If you collect less volume than what is recommended, the bags we are using here, we collect 450 mils of blood in 63 mils of anticoagulant, and that ratio is very critical. If you collect less blood than the anticoagulant, that means you are going to have excess citrate, and citrate is seen to be poisonous. And if you collect more blood than what the anticoagulant can handle, that means, one, there will not be enough nutrients for this blood. It will be used up. And two, the anticoagulant will not be enough, so you end up with microclots. Those of you who are from the hospital, you know when you have blood with microclots, it cannot go through the giving set. So we need to observe this right from the time of collection so that our blood is usable, is safe, and effective. So precautions observed in preparing blood components. You need adequate mixing of blood with anticoagulant. If you don't mix it well, then you end up with clots. Platelet preparation, blood should be kept at room temperature and should be separated within 6 to 8 hours. So this is whole blood. As I was telling you, we need 450 mils against 63 mils of anticoagulant, and should be kept in between 1 to 6. And this is a big challenge again. In most cases, hospitals come to the blood bank without ice packs, and some of them are traveling 3-4 hours on the road, and The challenge is this blood, if you don't keep it within this acceptable range, you are going to end up with hemolysis. And once this blood is hemolyzed, you are going to have free hemoglobin in your blood, and free hemoglobin is seen to be, again, harmful to the recipient. So we need to take care when we are handling blood that the temperature, the storage and transportation temperature, especially for red cells, should be within 1 to 6 degrees. So if you are from the hospital and you have been coming to blood bank, we want to encourage you to maintain this temperature for the safety of this unit so that it can be beneficial to the recipient. Shelf life, depending on the anticoagulant you use, CPD, 21 days, CPDA, 35 days. Administration is through a standard blood filter. And when you are transfusing this whole blood, you should do it within 4 hours of issue. Don't leave the unit of blood in the ward for many hours because it will affect its function. Fresh blood, by definition, is between 12 to 24 hours old, and usually we need this for neonatal exchange transfusion. All blood is from 24 hours to 35 days, depending on the anticoagulant you use. If it is CPDA, it is 21 days. If it is CPDA, 35 days. And the indication is for acute active blood loss with hypovolemia. Contraindication is risk of volume overload in chronic anemia and incipient cardiac failure. If the patient has chronic anemia and you give whole blood, you risk overload. So in most cases, you may need red cell concentrate for chronic anemias rather than whole blood. Administration must be ABO and RESAS-D compatible. This is done at hospital level. Compatibility is done at hospital level. In Uganda, we don't do cross-match in the blood center. And we encourage you not to add medication to the unit. I know sometimes maybe you want to make shortcuts. You are saying, now I have already pricked the patient. I don't want to prick the second time to do medication. Please, never add medication to the unit of blood. And use blood administration set, not the others which are used for other fluids. And the dosage is 1 unit should be able to increase HB of 1 gram per deciliter. Red cell concentrate, as I told you earlier on, we do prepare this, although in the most crude way, that is by sedimentation of red cells. And our PCV should be between 60 to 70, where we remove 30% of the plasma, and all the leukocytes and platelets are in that pack. Then we also have red cells which are prepared by centrifugation. The PCV should be between 70 to 80, and 50% of the plasma and leukocytes and platelets are there if you don't leukoreduce. And red cell with additive SAGAM, the PCV should be 50 to 60, minimum plasma, all the leukocytes are there and platelets are there. The advantages of red cell concentrate are the oxygen carrying capacity equal to that of whole blood, half the volume. Significantly decreases levels of isoagglutinins, metabolites, and electrolytes. Most of these are removed as you remove the plasma. The shelf life for red cells is 35 days if you don't add SAGAM. If you add SAGAM to the red cell concentrate, then it should last 42 days. Again, the storage temperature for the red cell concentrate is between 1 to 6 degrees, and the indications are the restore oxygen carrying capacity of symptomatic anemia and surgical blood loss. For platelet concentrate, as I told you earlier on, there are 2 sources of the platelet product. That is from whole blood, like what we practice in Uganda, but you can also get from apheresis. The platelet concentrates are prepared from whole blood, either using the platelet-rich plasma or the Buffy-Coat method. The platelet-rich plasma is basically the American system, and the Buffy-Coat is basically the European system. And in Uganda, we have adopted the American system. We prepare our platelet concentrate using the platelet-rich plasma method. And in this process, the process of preparing this platelet concentrate, we use a light spin to begin with, and then we remove the platelet-rich plasma from the red cells. Then we do a hard spin to remove the platelet-poor plasma, and we are left with platelet concentrate. We usually resuspend it in between 50 to 80 mils. So we start with that unit of whole blood, rich plasma, platelet-rich plasma, where we separate the platelet-poor plasma from the platelet concentrate. This is how the platelet concentrate will look like, and we keep it for 5 days under constant agitation. Again, platelets, their nature, they tend to clump together all the time. So if you are to keep it viable, then you need to keep shaking it so that you avoid them clumping. The storage temperature is between 20 to 24 degrees, and the volume is between 50 to 80. Again, this volume is important in maintaining the pH. Once the pH is not maintained, then the pH affects the function of the platelets. So the volume here is also critical. And the content of the bag is usually 5.5 times 10 to the power 10 of the platelet count, and of course the plasma, and then we have white cells in it. I told you earlier on, we don't do leukoreduction. We don't remove white blood cells from our platelet concentrate. So if you are transfusing these platelets, you should be aware that there are also white cells in them. They are mainly for severe thrombocytopenia, platelet dysfunction, and bleeding. The platelet concentrate is mainly being used in the Cancer Institute. That's where it's most requested for. And we expect that when you transfuse this unit of platelet concentrate, you should be able to raise your platelet count by between 5,000 to 10,000 microliter per unit. Administration should also be ABO and research compatible. This is being observed, except for a few cases where I've seen a doctor request and say, I think if you don't have the blood group I need, please give me the other, whatever you have, I'm going to use it like that. But we should observe the ABO and research compatibility when we are transfusing platelet. And we should use blood administration or platelet infusion set. This is very important because if you use the wrong infusion set, you might have all your platelets stuck up in the filters, and you may not get any into your recipient. So it is important that you use the correct infusion set. And the dosage is 1 unit of platelet concentrate per 10 kilogram body weight. And in Uganda, this is still a challenge. We are doing some studies to see whether what we are practicing is giving the effect which is expected. The increment, platelet increment after transfusion is usually less in patients with this DIC, septicemia. So these conditions will affect platelet transfusion. Apheresis platelet, also known as single donor platelets. We don't have it in Uganda, but doesn't stop you from knowing something about it. Just one donation from one donor is equivalent to 6 random donor platelet units, and it contains 3 times 10 to the power 11 platelets. Of course, you will need only one of these units, and it will be enough for that patient, rather than in our case where you need 6 of those units just for one adult dose. So the advantages is large dose from a single exposure. So if we reduce the risk of infection, because when you are transfusing 6 different units, there's a higher risk of infection. And the disadvantages, as I told you earlier on, it is expensive and time consuming. I told you take like 3 hours just to get that unit. Precautions and storage. The pH should never fall below 6. Decline in pH is caused to cause changes in the shape of platelets from disc to sphere. Once the changes are there, then that platelet is now non-functional, and it will not help the recipient. Agitation during storage will help in exchange of gases, and exchange of gases also maintain the pH and reduce the formation of aggregates. As I was telling you earlier, platelets have the tendency of aggregating all the time. So we need to keep blood always in the constant agitation. It will help to extend its life and also help it to be for the gaseous exchange. Now, if these bags are porous, it allows oxygen to go in and carbon dioxide to come out. So we need to give it opportunity to do this when you keep on agitating it. We also have fresh frozen plasma. Plasma, along with anticoagulant preservative, and the volume is usually between 220 to 300 mils. Also, we prepare it from whole blood within 6 to 8 hours of donation. Here we are looking at preserving all the coagulation factors, the heat-liable coagulation factors, those factors which are affected by heat. So we need to separate the plasma from whole blood within the shortest time possible so that we have all those elements we are looking for and freeze it. The maximum level of coating factors and plasma proteins, the storage temperature is usually -20, and the shelf life, if you maintain this temperature, you should be able to keep it for 1 year. But in Uganda, we normally have the challenge of power fluctuations, and so if you don't keep that temperature, then the shelf life is reduced. Again, the administration must be ABO compatible because you have all these antibodies and stuff which will affect if you don't give it to the right group. And the infusion should be 6 hours after thawing. We keep them in a frozen state, so after thawing, you should use it within 6 hours, and you should use the standard administration set. Dosage is 15 to 30 mils per kilogram weight, and usually we don't need this for volume expansion because you are putting this down at a risk. You rather use something else, not plasma, and you shouldn't use it for nutrition support and wound healing. Indications are for these patients who are deficient in factor 2, 5, 10, and 11, in DIC, massive transfusion, plasma exchange, severe immunodeficiency, urgent reversal of warfarin therapy. These are the conditions where we need the FFP transfusion. Cryoprecipitate, cold precipitate. These are cold precipitate proteins of plasma. Again, we prepare it in Uganda, but not in large quantities. You start by preparing the fresh frozen plasma, and you thaw it at 4 degrees to remove the supernatant, and you spin it at a hard spin so that your precipitate can settle down, and you remove the excess plasma. The advantage is you can administer a large amount of factor 8 without overloading the recipient, and the volume is between 10 to 20 mils. The shelf life is 1 year if you keep it under the required storage temperature and you thawed for 6 hours. The required temperature is usually -20. The contents are factor 8, fibrinogen, factor 13, von Willebrand's factor. Transfusion criteria again is ABO compatibility, not required, and indications are for correction of factor 8 deficiency, von Willebrand disease, and replacement of fibrinogen in postpartum hemorrhage. So we can use this in those conditions. So my conclusion is preparation of blood components has been made possible by the introduction of plastic bags. And blood components are prepared either from whole blood units or by apheresis. it is possible to transfuse only the component, only the blood component the patient needs. 1 unit of whole blood can benefit more than one recipient.